So let's assume that a patient is diagnosed with an OCD for the first time, maybe on an x-ray. If they're asymptomatic, generally we leave them alone. But if they're not asymptomatic and they're found on an x-ray, the next step is to get an MRI. The MRI for us is going to show us a few things. One, it's going to show us what the size of it is and where is the location. Now, most commonly in the knee, it's something called the medial femoral condyle, or the inside part of the weight-bearing surface of the femur. But I've seen it in various spots. It's more rare, but you can see it on the kneecap, patella, trochlea, lateral femoral condyle, even the tibial plateau. Again, less common, but still there. And then we look at an MRI, we want to see if there's fluid underneath. If there's fluid underneath, we're concerned that maybe it's a loose OCD or it has its potential that it could pull off that thing that we had talked about previously. If it's more secure, we may just watch it. If there's still continue to be pain there, the first step is to try no weight bearing or no weight on this. That can be helpful in many cases. If that doesn't work, the next step is to maybe consider surgical intervention. If it's something where we're not feeling strongly that it's loose and maybe that there's just signal underneath there and it's painful, we'll try drilling. And there's two types of drilling. We can drill backwards, so that way we don't actually go into the cartilage, or we can drill, so that's retrograde, or we can drill antegrade, where we go into the cartilage. Again, the goal here is to treat this without doing any further intervention to the cartilage itself. And even if you go antegrade, it's fairly low in terms of damage because you're making very, very, very small poke holes in the cartilage. If it gets more extreme and you're worried that it's loose, then we may go in there and consider a surgical fixation of this. So what we do with this, and you can see our videos on our website, is we actually open or hinge open this hole, and we can keep it still attached, clean up the undersurface, because remember, it's a separation of the bone, the two pieces of bone, and there's places there where it's not healed. We can clean that up, get it to heal, and then we close it back down like a trap door, and this can be done all arthroscopically, and then we can fix it usually with screws. The newer screws we're using, we do have metal options, which are really good, but those tend to have to come out. We have newer options and some innovative options of screws that turn into bone or screws that dissolve over time. And so the patient really never has to worry about removal of hardware. And if there's ever an issue, it can be easily removed without any worries about metal.